approach the patients these days with all these things we know? Well, I'll tell you the way I do it. When you examine a patient with macular degeneration, the first time you see them, you have to determine what stage of the disease they are. I tell my patients, everybody starts with dry changes of macular degeneration. 20% of patients develop wet lesions. That's the one we treat. It's better than to say there are two kinds, the wet and the dry. There's treatment for the wet, there's no treatment for the dry. So everybody starts with dry. Well, we have to distinguish that among the patients with dry macular degeneration, there is a group that develop atrophy of the tissues. What's atrophy? I explain to my patients, if you walk in the carpet 100 times for 2 years, eventually wears off, and there's no more tissue. So atrophy means absence of the tissues wear off, and they don't exist anymore. That form of macular degeneration, the dry atrophic one, is the one that's have no treatment at all at the present time. The other group of patients that have the pigmented lesions, the little drusen, the little white spots, those are the dry, and those are the ones that are prone to develop wet lesions. The ones who have the atrophy usually don't develop wet lesions, and doesn't matter, they don't have central vision anymore. So the ones who have the dry, we have to classify them. I have to tell my patient, you're at high risk to have a wet lesion, you're at low risk. The high-risk patients are the ones that have large drusen, which are little white spots in the back of the eye. We see that, they are big. And the ones with the small ones, they are lower risk. So we tell them you're at high risk, there's no wet lesions now, no treatment needed. You have to check for distortion, to give you all the charts. If distortion develops, we treat. Otherwise, you don't need a treatment. And we do this patient regularly. Vitamins, as you know, can decrease the chance of having a wet lesion. And that's the way we approach it now. And we look at these patients, pictures, angiography, and OCT. And the great thing right now is that we don't have to do an emergency treatment. When we used to do lasers, either this lesion is outside of the center, come for treatment today, 2 days will be too late. Fortunately, now there's more leeway. If you have distortion indicating an early wet lesion, take a week, no matter, you can come over and we start the treatments. And the treatments we do, I prefer to start with Avastin. Avastin, I still think is the more powerful of the 3 drugs we have available. It's a more basic product. So I like to start with Avastin. It has anti-inflammatory effect and anti-angiogenic effect, so blocks production of abnormal vessels. If Avastin doesn't work, I go to Eylea, and then if Eylea doesn't work, go to Lucentis. It's an interesting phenomenon we are seeing. It's called tachyphylaxis. It's almost like resistance to the drug. You use one injection that works for a year, then after a year doesn't work. Okay, switch to the other one, use the other one, and after a while it doesn't work, you can go back to the other one. So we have a lot of leeway to go back and forth between these drugs. Unfortunately, the other thing is, these drugs, they work for any condition in the eye that develops abnormal vessels, not only macular degeneration. Andrew Streets, as Gary mentioned, he had that condition, and breaks in the choroid, trauma can produce abnormal vessels, scars, etc. Many conditions. The drugs work for all of them. The other advantage of the drug is that you don't have to find out where the abnormal vessels is. You inject it in the eye and treats everything. So what do I tell my patient when I said you have wet macular degeneration and we are going to start treatments? We said, with this treatment, you have a 90% chance to stop this process so it won't get any worse. So if you start the treatment when the vision is good, you got an excellent chance to keep that 90%. If the vision is decreased, you got a good 60-70% chance to improve vision. Unfortunately, that doesn't happen. So the earlier we do the treatment, the better chance to keep good vision with that 90%. And like anything else in medicine, in some patients nothing works. 10% of patients, you do the 3 drugs, do photodynamic therapy, and it doesn't work. The other problem we have now is how many times can you do this treatment? Fortunately, you can do it forever. I have patients that come, every 3 months for treatments, every 6 months, and that's the way it works. Unfortunately, some patients need to come every 6 weeks for 1, 2 years, 3 years. And most of them, if the vision is good, they don't mind. One thing we explain to the patients, if this lesion is coming very often, there is 2 ways to manage. One, you can come when you have the symptom. Other says, I'm afraid, why do we do maintenance? And some of my patients get a treatment every 3 months, just as a safety feature, and they can function. So that's what we're doing now. So is laser out of the question this day and age? Still we use it sometimes. Macular degeneration in, I would say, less than 5% of cases can produce abnormal vessels outside of the center of the retina. And those we can treat with laser, because it doesn't matter. And the scar outside of the macula, don't need it. 1 session, 2 sessions, and you're done. You don't need to do shots. So laser still have some role in the treatment of macular degeneration. So what's the future of this type of treatment? We need to find a drug that will last longer. Again, diabetic retinopathy is ahead of macular degeneration. Diabetic patients with edema, with fluid in the center of the macula, also get shots every so often. But they have developed a drug. There are actually 2 drugs, one called Ozurdex, it's a form of cortisone that you inject like a small pellet in the eye that dissolves in 3 months and releases the medication. Okay, and there's another one called Iluvien that you inject it in the eye, a little pellet that dissolves in 3 years. So you have a medication that works for 3 years. It's of course more expensive, $5,000. But 3 years, injections every 6 months at $2,000 becomes cheaper. So I think one of the problems is that the chemical composition of this Avastin Lucentis is such that cannot be delivered in sustained fashion. Only can deliver straight and wait until it dies off. But I think in the future, this is what we're waiting for, drugs that will last longer. So what about these new drugs? Many of you probably has been asked to participate in a clinical trial to a new drug. Are we doing any new drugs? Avastin started in 2005. Lucentis, 2006, almost at the same time. Eylea, 2011. Since then, no new drugs have been developed. There are 12 drugs that have been tried during these past 5 years, and we participate in at least 4 of them, trying to see if they work better. So far, neither one works better for wet macular degeneration. For dry macular degeneration, there are 6 drugs that we have tried, and there is one that appears to be effective. It's called lampabizumab. The initial trial showed that can stop the disease. Those are the atrophic ones, the ones that the tissues wear off. If you catch it early enough and you give this drug every 2-3 months, you can stop the progression of that disease. So we're waiting for that to be approved by the FDA. So if I think about, I was thinking when I was preparing this lecture, are we doing any good altogether? With all these things, the patients coming more often, having shots. Doctors are doing better, right? But are the patients doing better? So I said, is legal blindness less? And there's a study Dr. Bressler in Hopkins did. In 2002, when we look at all the patients that were legally blind, 29% of them have macular degeneration. Did the same study in 2008, only 2% were due to macular degeneration. So the incidence of legal blindness has decreased tremendously with the use of these drugs, from 29 to only 2%. So when you have these treatments, and we do it early enough, you have 40% chance better to retain good vision. The other thing is you could maintain your independence. The number of admissions to nursing homes and assisted care facilities due to poor vision has diminished tremendously because the patient's still active. Patients can drive. Some of my patients come for the shots. Come one day for the exam. Do I need the shots? I come back another day. They come without dilation, then they drive themselves. I have at least, I think, 3 truck drivers, commercial truck drivers, that they have this condition. One of them started at age 50, and he keeps shots every 3 months. This is not, I keep driving every 3 months. When he has to do his test, his vision test, he comes 2 weeks before, so he can pass the test. He's keeping 20/30, 20/40, he requires 20/40. Sometimes he drops to 20/50, 20/60. Remember, both eyes have to be in shape. But 5 years, he's still driving his truck, thanks to these drugs, and of course he doesn't mind.